Swayam Prabha. Digital India. Educated India.
Welcome back. In lecture 49, we continue with the second part of urban health services. The different concepts that we will cover in this particular lecture are on involvement of ULBs, health status and issues in urban areas, healthcare provision in urban areas, core UPHC services, other UPHC services, the organogram of UPHC, governance of UPHC and characteristics of model UPHCs. So, as we discussed in our earlier lecture that it's the ULB which conducts all the different programs, it provides all the finances for conducting all these programs and all, and in large urban areas it's the municipality which is in full charge of conducting all healthcare services, whereas in smaller urban areas we have the health department as well as the ULB which participates in provision of healthcare services. Now, the role of ULB is to plan and implement all sorts of health services and all the different national programs or the national missions that are conducted. Now, NUHM, the National Urban Health Mission programs are implemented by the municipal bodies, and health department along with ULBs for smaller cities, that we were just discussing that, and primary healthcare services setup is similar in all ULBs independent of the provider. So, either it is provided by the municipal body or it is provided by the health department. The primary healthcare service, the facility, the organization setup or what services it provides is exactly same in all cases. Now, what are the job of a primary healthcare, what are the primary healthcare services that are provided to the people? Epidemic control, including control of vector-borne diseases. This we will cover in a different lecture in our last module. Disease surveillance programs, treatment and disposal of sewage, solid waste management including carcass disposal, drinking water supply, sanitation. So, this part is all part of urban utilities and services in solid waste management, sanitation and so on. Then other than that, dangerous and offensive trade licensing like provision of slaughterhouses, their location, how to manage their waste and so on, cinemas, restaurants, because there are some kinds of, there are chances of outbreaks and all this stuff from here. There are a lot of people agglomerate over here. And then food safety, overall food safety in the urban area. So, there is a department with health inspectors or food inspectors who come and check certain restaurants and all. Road safety including street lighting, birth and death registrations, management of cremations and burials, control of stray dogs and rabies control, air pollution, convergence of slum redevelopment and affordable housing, welfare schemes of vulnerable populations. So, all these are taken care by the ULB. But directly via the primary healthcare center, not everything could be taken care. Like the primary healthcare center doesn't look into these aspects, it doesn't look into these aspects definitely, but lot of things could be looked at by the primary healthcare center as well. Now, when we talk about the health status or issues in urban areas, particularly in India, we see that the coronary heart diseases are prevalent among 8 to 10% of the adult people and people above 10 years and older. So, that is in Indian urban areas. So, that's a huge amount of people are affected by this kind of diseases. Similarly, diabetes affects around 11.8% of the people in urban areas. Hypertension 20 to 40%, like there are different levels of hypertension and some people are not even aware they have got hypertension. Then around 66.7 lakh cases of asthma occurs in urban areas. That was the figure for the year 2011. Dental caries is more prevalent in urban areas. Higher rates of traffic accident, domestic violence, mental health cases, and similarly drug, tobacco and alcohol use is also more in urban areas. So, that's why the care that should be provided in urban areas should also focus on all these different problems specifically in addition to the standard healthcare services. Now, the other issue in urban areas is the private sector. because urban areas, as we are saying earlier, that people are motivated to make it, to run this healthcare service as a business. So they're motivated by profit, and this is usually, this kind of healthcare services are provided by individual practitioners, small nursing homes, and usually these are 1 to 20 bed nursing homes, and mostly they look into the provision of curative care. But the problem is, whenever they are providing this kind of services, there are a lot of issues with that. For example, there is no uniformity of distribution of these services. So there are supply gaps in certain areas. So we cannot depend just on private sector services. So there are private sector services which are provided in urban areas, but there we have to be also concerned about where to set up this kind of facilities, or where to allow to set up this kind of facilities. The National Rural Urban Health Mission focuses on the poor people or the vulnerable groups, right? But for general people and all, because most of them, they don't go to the primary health centers, they will go to these private facilities, because in urban areas people can afford this kind of healthcare services, and usually these are more, I would say that not about the quality, but I would say that the overall quality of the place and all these things definitely will be much more improved, and because people are paying for that, right? But still, there is a lot of gaps in provision of these services. Some areas of the city have private healthcare, but other areas of the city doesn't have. So when government provides primary healthcare services, in that case, it should look into this distribution of private healthcare entities as well, and then decide where to locate its own healthcare facilities so that people are not deprived. Then need for uniform standards and treatment protocols. So because these are private institutes, they have their own protocols or own ways of treating. So there has to be some amount of standardization so that we provide uniform care for different people. Then need for cost controls and quality assurance. So these are definitely problems. Small facilities, they don't have that much quality, whereas large facilities can charge, they can charge a lot of money. So there has to be some control in that regard. Regulations to protect consumer interest and enforcement system. Like suppose somebody complains that there is some problem with some healthcare facilities, how do you deal with that? And then supporting NGOs and charitable organizations so that they can provide reasonable quality care at affordable rates. So usually we have seen that NGOs, organizations, they can help in blood donation camps, they help in provision of certain campaigns. So of course we have to involve them because they can provide the service at a reasonable price. And finally, to serve the poor in underserved areas, we can make the private sector also serve the poor. Usually they don't because they cannot make money. But if there certain incentives are given or certain kind of supports are given, they may be also interested to serve the poor as well. Now, earlier the primary healthcare in India used to focus on only maternal and child health, and maybe for some communicable diseases. This was mostly the focus. Whereas other kinds of diseases like non-communicable diseases or lifestyle diseases, and for specific kind of problems, specific kind of operations, there was a lot of fragmentation of care or fragmentation of services. So that was a problem. And usually the expenditure that people have to dish out for healthcare services was much, much higher. And that usually affected the quality of life, because there are a lot of poor people in the urban areas who cannot afford this kind of healthcare expenditure, or if they are unlucky to fall for some disease during a certain year, they would have problems, maintaining their family for the, for other aspects as well. So primary healthcare and so usually the primary healthcare services as well as tertiary and secondary care institutions. What was happening in urban areas earlier was the basic primary healthcare was provided by this larger secondary care institutions as well as the tertiary care institutions, which shouldn't be, right? Because tertiary care institutions or secondary care institutions, they are there to deal with more complicated cases. They are going to deal with larger complicated operations, or they should have diagnostic system for specific diseases and so on, right? So this is specialized healthcare. So for basic problems, basic healthcare issues, if you go there, you are unnecessarily denying other peoples to get the care they should get from this kind of institutions. So earlier it was unstructured, but in rural areas this was structured because of the Rural Health Mission. Primary healthcare centers were there, and then there were community centers and so on. So this order was there. So after this urban rural health mission came in, this kind of structure was also brought to the urban areas as well. So and along with that, the private sector in urban areas has problems with accessibility, means affordability of the people. That means not everybody has access to private healthcare and so on. So these were some of the issues which were looked at, and then a comprehensive primary healthcare services in urban areas. How to do that? That was formulated in the National Urban Health Mission. So we have done a lot of discussions in the National Urban Health Mission in the previous lecture, and to say that one of the primary component of that is the urban primary healthcare center, because that's the way you engage with the community. So that's the first place where community gets engaged, right, in terms of healthcare service provision from the government. So the urban primary healthcare center is responsible for primary healthcare and public health needs of well-defined catchment. So that means the catchment is also fixed for each primary healthcare center. That means it is responsible for providing services in that particular catchment. And people have cards as well, so that they are linked with that particular health center. You cannot go to another health center directly. So the healthcare team can conduct outreach sessions, special camps. They will do home visits via ashas and mas and so on, so that we are providing direct service to the people. And finally, community mobilization can also happen for certain immunization drives and all these things through coordination, through mass Mahila Arogya Samitis, as well as they can also help in coordination of the reference from the community itself directly to some secondary or tertiary healthcare center as well, depending on the severity of the disease and so on. So UPHCs are designed to provide curative, preventive, promotive, rehabilitative and palliative care. This we have discussed as well earlier as well, and they are directly linked with the community at one side, as well as the tertiary and secondary care with the other side through the referral system. So a formal reference system has now come into place. The reference system also, as we have discussed, it helps to manage the resources and serves the deserving. Then universal access to quality services near to each house within a particular limit. You will have a primary health center, you don't have to travel a lot, and a certain assured minimum package of services will be provided to you without any denial of any kind of services. Finally, this has reduced the out-of-pocket cost expenditure for the people. The drug, diagnostic, these are all free. And then culturally appropriate healthcare and counseling. And finally, needs of urban marginalized population has been taken into account. So that's the role of the urban primary healthcare center. So the core UPHC services that are provided, these are provided by healthcare workers, and these are workers such as medical officers, public health managers, staff nurse, ANMs, ASHAs, and UPHC, the overall team, the organization and the management team. So they receive proper training and all, and then they provide this kind of services. So what they provide directly, they provide care in pregnancy and childbirth. So you can you have direct childbirth support and all in the primary healthcare centers and very near to your house. Neonatal and infant healthcare services, childhood and adolescent healthcare services including immunization programs for the children, family planning, contraceptive services and other reproductive healthcare services. Then common communicable diseases and general out-of-patient care, management of those can be taken care of by this primary healthcare center. So that means in case you have certain flu and this kind of diseases, you can go there and get treatment. Management of communicable diseases through national health programs. So how to reduce the communicable diseases, how to monitor them, all this could be done under different national health programs through these particular centers. Screening and management of non-communicable diseases. You can do a testing of the community to find out how much people are affected and so on, even though they don't come and report that. And then these are non-communicable diseases such as obesity, hypertension, this mental health issues, and all these things could be taken care of through this kind of screening programs. Then screening and basic management of mental health alignments, that's what I was just telling you about. Care for common ophthalmic and ENT problems, eye care, like for example, certain kinds of operations could be done through via camps and all, through which you can do certain kinds of eye treatment and all, particularly for the older people. Basic dental care provision, geriatric and palliative healthcare services, and finally trauma care and emergency medical services could be also provided by the primary healthcare center. But of course, if the problem is critical, then you have to refer it to a higher order facility. So in addition, there are certain other functions this UPHC provides. For example, population enumeration, life cycle appropriate services for different age groups, certain kinds of services has to be provided. Screening for non-communicable diseases, we mentioned that. Early identification of communicable diseases, early outbreak identification. So these two are similar, and their management in case certain kinds of viruses are passing, how to control that and so on. Treatment referrals and follow-ups. Social and environmental determinants affecting health. If in the community, if in that particular locality, there are some factors which are leading to certain kinds of health problems. Like for example, there is a lot of water body where there are a lot of mosquitoes. So how that can be controlled to reduce the disease itself, right? So this kind of social and environmental determinants that also are investigated, and this is usually done by the ASA and MAS and supported by ANMs and the primary, this health manager. Then integration and collaboration with ULBs and different government departments. Like for example, if you are doing a collaboration with the schools, that means we can conduct certain programs with schools, then the education department also has to be collaborated with. Then linkages with integrated child development services and homeless shelters, housing programs and other stakeholders. So these are the different linkages that has to be created with the health program. And then planned specialist consultation in certain cases, UPHCs can also provide that. So to broadly, summarize, we can say that UPHCs, first of all, it provides in-facility services, then outreach services, convergence with urban development like Swachh Bharat, and all this coordination like certain environmental and other issues which is causing certain health problems that could be taken care by sanitation and all these things. So that kind of coordination. Multi-directional and assured referrals. So you can refer in both directions. So this referrals is assured now. Population-based screenings for non-communicable diseases and community processes such as community interventions and home visit by ASHAs, ANMs, MAS and so on. So this is how a comprehensive service is provided via the UPHCs. So this is the overall structure of UPHCs. You can see that for every 50 to 100 households, there is the Mahila Arogya Samiti. Then this ASHA or community health volunteer, which is for 200 to 500 households. So one ASHA can manage multiple Mahila Arogya Samitis. Then one ANM is there. He or she conducts outreach sessions in area on a weekly basis. Whichever areas, like she can do that in 4 areas of under this particular primary health center. So it is done for for 10,000 people, we have got one ANM. So you can see that for every 2,500 people, we have got one ASHA. So that means this ANM will go to different jurisdictions in different areas in different weeks to cover 10,000 people. So if she covers 2,500 people every week, she will cover 10,000 people. So if an area has got more than 10,000 people, then we have got multiple ANMs as well. Then in the UPHC, the staff, it's provided for 50,000 population mostly. So this is primary health center where you have got one medical officer, then a part-time medical officer, one nurse, then pharmacists, lab technicians, and so on, right? So this is the structure of the UPHCs. And for the community health center, which is one level up, this has got this inpatient facilities for 20 to 50 beds in case the population is around 2.5 lakh, a smaller area, where it's a 100-bedded facility in larger cities where the population is more than 5 lakhs. So in this particular case, all the operations and all these things are done at the urban this community health center level. So this UPHCs doesn't have facilities for operations and so on, which could be done at the community health center. So the governance of UPHCs are done via different ways. Of course, the ULB is the overall, looks into the health department of the government, as well as the ULB is in charge. But we also have the Rogi Kalyan Shamitis, or also known as patient welfare committees, which what it does is it's a committee formed of members of the community, and they actually determine that the overall feedback of the community on that particular UPHCs, if the services are provided are fine, and they ensure public participation and so on. So they meet every 2 months, and the reports that they create, they are helpful. They inform about what has been achieved, what are the problems or shortcomings, what are the challenges, what sort of finances would be required. So all these are done by this Rogi Kalyan Samiti. So it's something by the people themselves for their own benefit. Then there are certain public consultations and public information programs as well. That means discussions and community consultations are held based on where the UPHC should be located inside a community. So that is one part, and also discussions on how it should perform and all this. Then signages should be in local language spoken by most of the service users. So that in that particular area, based on the major languages, those has to be provided. And overall ensuring quality care, and this could be done by ranking and scoring of UPHCs, and this could be done via the quality of care framework, which was made in 2013 by the Ministry of Health and Family Welfare and NHA, this one. And then CARE guidelines for good upkeep of UPHCs, how to clean and all this, how to maintain hygiene and all this is provided by this guidelines. So this is how you ensure the overall working of the UPHCs. Some of the characteristics of model UPHCs could be listed as good visibility with standardized color coding and signages, and nice exterior facades so that people are attracted to go there. Clean and pleasant surroundings and patient-friendly environments and waiting areas. It should be disabled friendly. Then senior citizens should be given preference in every aspects. Emergency facilities and registration counter. Then availability of wheelchairs, display of relevant communication or information, and then co-locating with Ayush centers could be also co-located with this. So this is this is how you can set up a UPHC, right? These are the different aspects which you should be careful about. And the outreach activities are also conducted by UPHCs in the community, and these are known as urban health and nutrition days. Some of them are known as like that. And in this case, the ANM organizes one outreach session per month in particular area, and if sometimes one primary health centers can have multiple ANMs if the size is large, and that means if the population, it serves a larger population, then it can even have 5 ANMs, and they will be conducting, each will be conducting 4 sessions per month. So overall 20 sessions are conducted with the community. Then they keep records of all these sessions, and specialized outreach activities could be also taken up, such as at community centers, schools, railway station, railway tracks, city outskirts, bus stands, underpasses, outside places of worship, and so on. So this is where this kind of specialized outreach activities could be conducted in the community. So these are some of the references you can study. To conclude, urban primary healthcare centers are designed to meet comprehensive healthcare requirements for the urban poor. ULBs along with government health departments are responsible for provision of healthcare services to primary healthcare facilities with linkages to both higher and community level facilities. Thank you.